yourself.
Whoops. Sorry. Huh? You can just find this is like pointer. But I'm scared they cannot see the one there. I know the back. Laser pointer. Thank you. Okay, once first our body will try to compensate it by activating the sympathetic nervous system and also release the catecholamine. Also will release the ADH and also angiotensin, which try to retain fluid in our body and subsequently will lead to vasoconstriction and increase our heart rate. So blood pressure will be trying to increase in the first stage. But as the shock progresses, if it didn't do anything, the body will become decompensated and cells will die and leads to multiple organ dysfunctions. So this is types of shock. Basically, there are 4 types of shock. Commonly we'll see is the distributed shock, which is constitute about 33 to 50% of the presentations. And it's different from 3 other types of shock because it's marked by the vasodilatations, where the other three types is vasoconstrictions. This can be due to either endotoxin release from the sepsis or neurogenic shocks with secondary to loss of the sympathetic tons, or it can happen in anaphylaxis where there's a release of bradykinin. Second is a hypovolemic shock, which is quite common in seeing in ED setting also. This is because of there's a reduce in intravascular fluid, subsequently will lead to decrease in stroke volume and also cardiac output. Hypovolemic shock can further divide into two: hemorrhagic shock, which happens in the trauma commonly, or GI bleed, or non-hemorrhagic shocks where fluid can loss from either from the skin, for example, in the case of burn, or profuse vomiting or diarrhea, which happens in the GI losses or third phase loss. Third type of shock is a cardiogenic shock, which happens when there is a left ventricular fails and there's causes a reduced heart contractility and also reduce your stroke volume and cardiac output also. So this can be seen in the case of myocardial infarctions, dysarrhythmia, either tachy or bradycardia, heart failure, or structural causes, for example, like in your valvular pathology. Last but not least is your obstructive shock, which constitute about 1%. It's caused by the obstructions of the blood flow from the right heart to the left heart, which is then reduce your preload and subsequently reduce your stroke volume and cardiac output also. This is the case in seen in pulmonary embolism, cardiac tamponade, or tension pneumothorax. So you already know that 4 types of the shock. Why is it important? Is because that we need to know how to tackle it down, their management according to their pathophysiology. So is there any way for us to know whether patient is in shock? The exact answer is no, but in clinically, we need to look carefully with, for the evidence of the insufficient tissue perfusion. For example, the patient's level consciousness, whether it's depressed or not, patient's periphery, is it cold, is it warm, or if the CBD inserted, how is the patient's urine output? Okay. Secondly, also have to look for any signs of a compensatory mechanism, for example, tachycardia, tachypnea, diaphoresis. There's some other specific things that you might look for, which guide you that patient is likely in shock, is patient's level consciousness, which is palpitations, heart rate more than 100, or R more than 22, or your systolic blood pressure less than 90 millimeter mercury. Pulse pressure, I mentioned here because it depends on the patient's underlying causes. If it's hypovolemic shock or any, it likely can be because you will see a narrow pulse pressure. But vital pulse pressure can also be seen, right, in the case of, for example, like aortic dissections. So it's important to monitor patient's pulse pressure along the way. Also, the urine output can be also one of the guide where there is a reduce less than 0.5 ml per digit per hour, like if patient is in shock also. So some lab findings that can support your finding is your lactate more than 3 millimole per liter, base excess less than -4, or your PCO2 less than 32 millimeter mercury. Okay, next. When patients comes to you, first thing we have to assess is to evaluate patient's ABC, airway, breathing, circulations. This is very important to all the patients that attend in the ED because you need to rule out any life-threatening conditions. Okay, once patient is here in ED, you put on your cardiac monitoring, you assess this patient quickly. Okay, you assess patient's GCS level and airway, breathing, and also circulations. So then you try, if you identify patient is slightly in shock, you need to think of the differential diagnosis according to the 4 types of the etiology. Okay, then once you have more clear directions, then you conduct a focused physical examinations and also a history. Okay. So then you use your adjunct to help you to further support your diagnosis and also to guide your treatments. These are the list of the some of the differential diagnosis where you get from your history. For example, if the patient came in with chest pain, likely for the cardiac or pulmonary causes, any significant findings or any murmurs from the heart, which can tell you whether patient's heart structural, having any valvular or any septal rupture. Then you'll look at the JVP, abdomens, and also generally. Your adjunct test will include your ultrasound, which commonly seen in ED and is quite useful. Your ECG, your X-ray, and also your blood investigations, which include your blood cancers. Okay. Ultrasound. So you get more details regarding the ultrasound. There's a RUSH protocol, which is called a rapid ultrasound in short, where we evaluate patients. It's a sequence of the ultrasound assessment. So it goes according to assess 3 of your physiological functions. One is from your heart, which is assess your pump, your cardiac status. Second, assess your tank, which is to assess your intravascular volume status by looking at the IVC, Morrison pouch, and also your lung. Third is your pipe, which is your circulatory system, which includes your aorta and also vein. So there's a mnemonic over your right side. It's HIMAT, H, heart, IVC, Morrison pouch, aorta and vein, and pleural, which is or pneumothorax. So this helps you to guide you what to look for during your ultrasound assessment. So this picture actually pretty sums out everything in one. First, you assess your heart, which is your pump. You put your probe at the parasternal area. You look at the parasternal long axis and short axis of the heart, a vital view and subcostal view. When you look at the heart, you should assess the heart contractility, whether it is a normal heart or is it slight depression or severe depressed, or is it in hyperdynamic status where you can see in volume deplete short. Okay. Once you look at the heart contractility, also look around the heart, see if there's any fluid surrounding the heart. If there is a presence of pericardial effusions, is it large enough to cause a cardiac tamponade? Then also look at your right ventricle, whether it's enlarged where you might see a D sign from your parasternal short axis of the left ventricle. So this might tells you that patients might having the right ventricular failure, which can happen in pulmonary embolism. Second, you look at your tank. When you look at the when you put your probe at the subcostal view, you just tilt your probe downwards, and then you see your IVC. So when you look at the IVC, you should assess patient's IVC size and also the collapsibility. This can tell you the patient's fluid status. Always remember when you look at the IVC, also have to look at the heart condition because that tells they are interrelated. Okay. Once you look at IVC, have a quick look over your lungs, the patient's lungs, and see if there's any signs of a sliding sign, which happens if there's an absence of it. If my patients might be having pneumothorax, then you look at the lungs whether if there's any presence of B lines where they might indicate a pulmonary edema. Okay. Then you move your probe into right and also left upper quadrant to see. First is to see the fluid either above the diaphragm, which can happen in the pleural effusions with the spine sign, or below your diaphragm, which is your Morrison pouch, and also your sphenorenal pouch. And to look for if there's any free fluid, not to forget your suprapubic regions. Okay. Third is your pipes, to look at your aorta. So your aorta to see if there's any aneurysm or any dissections, whether there is a presence of the intimal flaps, which is some hyperechoic things within your vessel. So here includes the cutoff point where you determine whether it's dilated or not. For aortic root is more than 3.8, thoracic aorta is more than 5, and also your abdominal aorta is more than 3 cm. You evaluate your aorta already. Last is your vein. Just have a quick look of your vein. look at the femoral and also popliteal. So you compress over it. If it's compressible, so likely there's a less chance for DVT. But if not compressible, patients more towards the patients might have a thrombosis in the vein. Okay. So next is once you already determine the patient is in shock. Next step, what is our next step? Go back to your ABC. Okay. Airway and also your breathing. You have to ask yourself whether patients need any ventilation support or not. Whether patient is in respiratory failure. Is the patient going to having respiratory collapse? If the answer is yes, then we should ask ourselves, should we intubate the patients? Okay. C is your circulations. Do you need to give fluid to the patients? If yes, the patient's correct to the fluid. Can we how many fluid that we should provide to the patients? And once you give the fluid, you have to ask yourself whether the patient is responding to the fluid or not. Do you need any additional things like your inotrope to support the patients? And last but not least, any specific things that you can be done for the patients according if you already identify types of the shock for the patients, because different types, different management. Okay, but specific for shock, if you are going to intubate patients, is there any difficulties that we face? Yes, for that, if you proceed for intubations, if you decided that patient is already taking it in respiratory failure, that you want to intubate patients, you always have to watch out three main things for patients, especially patients in shock, which is your HOP killer. H is hypotension, O is oxygen, and also pH is your acidosis. Okay. First, the risk for pericardial peri-intubation arrest is for hypertension is when, especially when the systolic blood pressure less than 70, shock index more than 0.8. And also remember that if you put patient on positive pressure ventilation, there will be raise in the intrathoracic pressure and subsequently reduce your venous return. Eventually, it will further bring down your BP. So quite tricky, right? To tackle it, there are three ways. One is you reduce your inductions and agents, and you give high dose of paralytic agents. So your low inductions agents, the choice will be ketamine, will be better choice, and it will induce the sympathetic surge. And also it's quite a good pain control medications. Other than that, you also can give high dose of rocuronium and also either rocuronium or succinylcholine. Second option is that you also can give a push dose of pressor, where you can give 0.5 to 2 mils or 5 to 20 mic of adrenaline prior to your intubations. This can be given every 2 to 5 minutes to try to bring out the BP before you put the patients sedated. Third is by the awake intubations. This one I already seen because it requires skill. Second is your equipment. And then also if you really want to proceed for awake intubations, you should apply the local anesthesia. First, you spray the pharynx. Second, you put some LA lignocaine over the posterior of the tongue, and eventually you need to spray the LA over the vocal cord. So it seems quite traumatizing, but it can be done. Okay. Second challenges will be your hypoxia. Some patients is still mostly if the patient is very tachymic and is in shock, there will be a rapid desaturations during your apnea waves, during your intubation period. So it's very important for you to provide sufficient oxygen prior to your intubations. How are you going to achieve that? Is by giving nasoprom 15 liters per minute with your high flow mask 15 liters per minute. This is your pre-oxygenations. So you provide it, try to achieve your SpO2 more than 95. If unable, then you have to think of the patients probably having some shunt physiological abnormality, which can happen in the pulmonary embolism. So this is that to tackle with it, you can give extra PEEP. So you provide patient PEEP, or also can change patient to an non-invasive positive pressure ventilations, which is also we call as a VAPOX, which is ventilator assisted pre-oxygenations. You sustain patients, try to give patients SpO2 more than 95, then only you proceed with your intubations. And this is also where we see in a delay sequence intubations. Third is by your back up head elevations, intubations, where you put the patient in the head elevator positions with the position slightly tilt out. This is to elevate your diaphragm and you cause output, increase your functional residual capacity, which helps you also in helps you in intubation patients more easily to ensure one goal. Third is your acidosis, which is your challenge. Try to avoid intubation. Try to avoid intubations before you actually settle down your acidosis, because when there is acidosis, there is a risk of a decomposition if you are unable to match the patient respiratory response to blow off the oxygen. Okay. And then if some patients, some might query whether we should give a bicarbonate for these patients, but it suggest is no, because it will worsen your acidosis by giving more carbon dioxide, because once you give bicarbonate, it will change to carbon dioxide in the body. So it produces more acidosis in the body. So this one is summarized a bit like generally what are you going to do. Basically, you give 0.5 mg per kg of ketamine. Normally it's 1 to 2 mg per kg, but in short, you give low dose, so 0.5. If the patient is not sedated, you may top out another 0.5 mg per kg until patient is fully sedated. Then if you proceed for your pre-oxygenations or ventilator assisted pre-oxygenation if the patient is unable to maintain an SpO2 more than 95, then you give your paralytic agents, which include rocuronium 1.6 mg per kg or your succinylcholine 2 mg per kg. Then continue with your AMIC pre-oxygenations, and once you're ready, you intubate the patients. So after that, you intubate the patients, always have to match the pre-intubation respiratory physiology. You may increase the patient's RR and also make sure to monitor the patient's ATCO2. Okay. Next, the challenges will be your fluid. So how many fluid to give? There's this thing what we call the fluid responsive, where it's to see the response of the stroke volume to fluid loading. So patients, if the patient is responsive to fluid, it means that there is an increase of the stroke volume of about 10 to 15% after receive about 500 ml of the steroid over 10 to 15 minutes. So they basically have a two parameter to determine to see whether the patient is responsive to the fluid or not. So first is the static. Static parameter is very it's only single parameter and only one point of time, which is then cause it less reliable. And the example include the CVP, PCWP, and also the X-ray. Then we have a dynamic parameter, which is more reliable, and it tells you relations between the heart and also lungs. You can see it through your air core, whereby you measure the VTI, which is the subaortic velocity time interval. So you do your passive leg raise. So you first you measure, you put the patients at a 45-degree pull-up positions with the leg is 180 degree. Then you can tilt the patients downwards. Then the leg raise for about 45 degrees. So by doing this, you can mimic giving a 50 to 100, 400 to 500 of blood flow back to the heart. We sort of like mimic like giving bolus to the patients. So during that time, you measure the VTI, you measure before and after. If there's an increase of a VTI of about 12% after you're doing the passive leg raise, meaning its patient is more likely to respond to the fluid. So meaning that you can give patients boluses. Okay. Other than VTI, you also can use IVC to measure, but this IVC, you have to have one criteria whereby the patients should be on ventilator, where they don't have any spontaneous breathing, because the breathing respirations should be put in the consistent depth and also the rate. So to easier, if you are still learning how to do a VTI, you can actually use the guide from the ultrasound by looking at the heart, whether patient is having normal or hyperdynamic cardiac functions. A small IVC with a high IVC collapsibility, where we always mention more than 50% collapsibility, with the absence of the E lines. So this might also tell the patient's likely is a fluid tolerance. In this case, where you can also give fluid. If on the other hand, patients have decreased collapsibility of IVC and also presence of B lines, more likely the patients having subclinical interstitial edema. So this is the time where you have to keep the fluid carefully. If the patients are unable to support, so is there any inotrope that we can give? Yes, there are 4 types that commonly being used in the ED. First and foremost is the noradrenaline. Noradrenaline is first choice for shock management, first choice of the vasopressor for management in shock, because it acts on both alpha 1 and also beta 1 adrenergic receptor, because it is very important vasodilator. Second, if the patient is in anaphylactic shock, then you may consider adrenaline, because it acts on the beta 1 adrenaline and adrenergic. So it will increase your cardiac output. Also, it can also be used as an add-on agents to the NOACs in the case of septic shock. Third, vasopressor is your dobutamine. It's a bit different from other because it also causes, also having vasodilation effect. So it can be used in the cardiogenic shock or as an add-on to NOAC for the cardiac output augmentations in septic shock with the myocardial dysfunctions. Last is your vasopressin. Vasopressin, it only helps to retain your fluid in your body, and it should always not as the first line. So it always as a top up to some other inotrope to maintain your BP. Okay, so just added on for some, according to the specific management for each class of the shock. First is your hemorrhagic hypovolemic shock. If you happen to having patients in hemorrhagic hypovolemic shock, basically it can further divided into 4 classes according to their severity and also estimated blood loss. If less than 50% is class 1, where you can see, for example, like patients giving blood donations, most of the time the vital sign will be stable, and you can just monitor patients. If the BP, if the heart rate starts being increased and the pulse pressure being narrow, so it's classified as class 2, mild. Most of the time, patients actually can still respond to your crystalloid fluid resuscitations. But blood products may or may not, but you have to find out the causes of the GI, causes for the hemorrhage. Third class is when the patient's having blood loss of about 31 to 40%, where the heart rate will be raised, BP will start dropping, and also with the narrow pulse pressure, patients may have tachypnea, and also uric output and GCS will start reducing, where patients will be confused and agitated. If you take the blood gas might show a base deficit of -6 to -10. This is time where you need to give the blood transfusions and also to go for operations immediately if indicated.
Of course, if there's more than 40% of the blood loss, it's classified as a class 4, which is in severe septic shock. Severe hypovolemic shock. This is shown by a marked heart tachycardia with a very low BP and also low pulse rate. Patients will be very tachyonic and also might not have any urine output. GCS might drop. The patient may be in comatose. So this you should activate your message transfusions protocol and also act according. Go for operations immediately to stop the bleeding. Okay. Second class of shock for specific management for the according to the classification of shock is the cardiogenic shock. So basically, heart failure can go according to these classifications, Noria and also Stevenson's classifications, where it goes according to whether patient is warm, dry, warm, wet, or cold, dry, cold, wet, according to their cardiac index and also their PCWP, whether patient is congested or is in hypoperfusion. So our focus will be cold, dry, and also cold, wet. This is because this shock happens when there's a hypoperfusion. Okay. So basically, actually, treatment for cardiogenic shock is quite simple. If the patient is cold, wet, you can just give inotrope to support the heart if there's a BP is low, and also when there's a wet, then you decompress by using the diuretics, which is your furosemide or GDN. Then dry cold actually is more specific. It's your obstructive shock, which is happens in the PE. This treatment by giving thrombolysis, and also if the BP low, then you support with the NOAC. Last that I would like to talk about is your septic shock. Septic shock basically can be further divided into warm shock and also cold shock. Warm shock it's very important for us to identify which stage of the patient is in, because warm shock warm shock is in the very first phase of the septic shock. It's characterized by high cardiac output and also low peripheral vascular resistance. This is when you can identify by having warm patients having warm peripheries and also fresh capillary with rebounding pulse. So aggressive management should be given during warm shock because it's still reversible. However, if the patient is in cold shock, which is a late stage, you should bear in mind that patient is in hypodynamic, where there is a low cardiac output and also high resistance shock. This is when you feel the patient is cold periphery with prolonged CRT and also poor peripheral pulses. So our management for septic shock, so basically this one is quite familiar with it. It's your 1 hour bundle. So you identify by measuring the patient's lactic level. Then you get your blood culture, start your antibiotic, and also you give a rapid and boluses fluid supplement for the patients by 30 mils per kg. And also you provide vasopressor early if there is any if patients still persistent having hypotension. Okay. So just to sum up, this one is just a slide, maybe you can read, but this is basically I include is because like for sepsis they might involve multi-organ if we did not treat earlier. Then this one is a summary for the causes, and last is your approach to shock. Okay, thank you. Any question before we proceed to my talk segment?
Morning everyone, I'm Justine. So I'm also post-call. I believe some of you guys also post-call. So my slide is very short, no worry. Nothing much, nothing to spoon feeding up. So actually it's a Q&A question. Hey. So for those master and those senior, try not to answer. I think it's too easy for you guys. Okay. So I think approach to shock, like the most hard part is to identify shock. So along our planning meeting, we were starting to see why we cannot detect the shock, why we didn't work out, and why we didn't give fluid like this. So we'll start with our question first. Okay. So one day you step into the yellow zone. The yellow zone is full blast with patients. So there's a 6 patient here with vital sign hanging on the wall. So which patient should you attend first and why? Okay, who answers the question? You can have 1 chocolate. The question is who should you attend first? This patient is shock and what should you do? So if no one, I will simply pick someone that I never see before. Okay. So you are the nearest. Yes, you can choose one of the patient. You choose Afiq. Okay, why? Why you choose Afiq?
Just to attend Afiq first because of the severe BP and the pulse rate.
Severe BP and the pulse rate. What wrongs with the pulse rate? 3 years old, pulse rate 55. Is it normal for the patient?
The patient might be into decompensated shock.
Patient might be in decompensated shock. Okay, yeah, it's correct. So with 3-year-old, pulse rate 55, what should you do?
Resuscitation because of the low BP.
Start resuscitation, okay. And then, what mean by start resuscitation?
Check ABCDE.
ABCDE, okay. ABCDE.
So for this one, the circulation wise should start inserting granular already and then
okay, if granular.
If we resus. So find out the cause of complication causing the cause of the decompensated shock.
Okay. So for Afiq, this patient actually is in decompensated shock with a heart rate 55. So according to the pediatric PALS, heart rate 55, you should start CPR. Heart rate 60 below for pediatric patient, straight away CPR. Okay, for this patient, it's supposed to be in resus, not in yellow zone. Anyway, so Afiq is a resus case. Okay, but here you can identify the compensated shock. Okay, this chocolate for you. Okay, come, let's go to the next patient. You can choose any patient you want. So you already done here. So from there, come. Anyone? Yeah, that's you, right? You're the nearest one. Okay, you can choose any patient you want. Who you like? Done with Afiq already. Afiq already pushed to this side. So no more Afiq.
Next one, I think I would like to go with Nurul.
Okay, Nurul, can I know one?
Because the pulse rate is high lah.
Pulse rate is high. Yung also high, yung also 120. Adam also high, 130. Why you choose Nurul? Pulse rate 140. Any other reason with the abnormal in the pulse rate?
Patient is also having fever.
Oh, I have patient also having fever. Your also fever, 39 degree with a pulse rate 120. Fever 39, more terrible. Why are you choose Nurul? Oh, is it because she's a girl? Okay, so it's okay. You try. So actually, Nurul, she has a high pulse rate. This is what we call as a tachycardia and fever. So by right, 1 degree of Celsius increase how many pulse rate in pulse rate? 10. So by right, neuro should be increase how many pulse rate? No, but you pay 100, so we increase to 110 maximum. So this patient is obviously in compensated shock. Okay, so neuro is in compensated shock with a pulse rate 140 but temperature 38. By right, 1 degree of temperature raise, you should at least the maximum of the heart rate for neuro is 110. So this patient should be started with fluid berapa? 10 cc per kg ya, jangan bagi 10 cc ya. Okay, thank you. So you deserve chocolate. Okay, so now we choose that side. I'm so sorry, the last one. You can see, you want to, okay. So which patient you are choosing now? Come on, you can do it, it's okay. You can try. Better than meeting a real life patient and then you panic there. Yeah. This is a fake patient now. You can choose a normal one, I don't mind. Fatima, okay? Fatima, any problem with her? Okay, since the topic is shock, is she in shock? By looking at the vital sign? Okay, maybe you're very tired. Maybe you want to let your friend try. So you can choose one of your friend. You want to give who? Okay, who you choose?
I choose Adam.
Okay, can you tell me why, Adam, you need to be focused on the patient?
So Adam is a Fatima because I would say that he's in shock, he's tachycardic, but it's not proportionate to the fever. So 37 to 38, but about 110, but it's 130. Might be impending shock. I will give you bonus first and assess back.
Can I know you are treated as a decompensated shock or compensated shock? Any reason to support you give fluid? We are tachycardic, okay, other than that? Okay. Any other reason? If you listen to Lynn lecture, will be some clue lah. Doesn't necessarily. The M can be metformin, the M can be on diet control. Okay, it's okay. You choose the correct question, and Adam should be the one who focus first lah. Okay, you deserve chocolate. Okay. So I will review the answer. Why we choose Adam, okay? So Adam actually is in a compensated shock. You look at the systolic pressure and diastolic pressure, the pulse pressure is narrow. So one of the criteria of the compensated shock is pulse pressure narrow and tachycardic also. So this patient has a disproportionate tachycardia also. So right. So without using before using all those scan, all advanced things first, at least you know how to interpret the vital sign lah. Okay. And then after that, only you touch you touch patient, include everything. So I think water sign is very basic thing you need to know lah. Okay. So this one is so other three maybe you can attend later. So the first one will outfit. The second and third one will no and attend your rubbish will be put later on. Okay. So this is my Q&A. So 6 questions only. So really not enough for chocolate. So don't forget about compensated shock. You don't forget about normal systolic pressure we raised by diastolic pressure and narrowing pulse pressure. A lot of patients that we miss off is narrowing pulse pressure and disproportionate tachycardia. Okay, normal pulse pressure is 40 mmHg and the 1 degree of temperature right spike increase by 10 lah. And if some center like to use shock index lah, shock index more than 1, that means patient in shock lah. Heart rate is divided by systolic blood pressure. You can see in Bentley chart also very famous now before COVID era come. So this patient, the compensated shock and Adam and the root obviously shock impact is more than 1 already. So memang in shock lah. So don't forget to attend the patient first, which is compensated shock. Okay, here is the basic thing lah for today. So for patient in a septic shock, right? There is always a discussion whether we should increase keep an MMP higher in the chronic hypertension or not. So according to the study, if a patient in septic shock whether in the patient chronic hypertension in septic shock, whether should we keep a high blood pressure, the answer is no because the mortality is the same. Whether you keep the systolic keep the MMP between 80 to 85, 65 to 70. It's the same mortality within the 28 days, no different. But the only benefit, if you read through this article, the only benefit that provided by the high blood pressure target group is the reduce the renal replacement therapy. Itu sahaja for this study. So generally, all patients in septic shock should keep 65 to 70 urine. No need to change so much. You prescribe patient on hypertension. Okay, so don't forget about lactate discordance. I meet a lot of patients which very ill, very septic shock, but the lactate is still normal. That is what we call lactate discordance. We don't always depend on lactate. Lactate sometimes I feel is very it's just helping me it doesn't really can help me to form a main diagnosis. Some you can see in this study they are taking for more than 5,000 patients. 5,000 patients in the cohort size, more than the 3 country ICU. They are comparing whether the lactate is normal or high in the shock patient So critical ill sepsis patient can have normal serum lactate also. So when a patient comes with septic shock, lactate is normal. Don't be quite surprised that this patient is no need to be resuscitated. Actually, yes, this patient needs to be resuscitated despite the lactate. You should treat the patient without looking at lactate. Okay, so there's always an event when some MO is trying to give bolus according to lactate, which is not correct. Okay, we should treat the patient clinically, but not looking at the lactate. Lactate is just help guiding me. Okay, so my take-home message is identify compensated shock. Nothing, no single laboratory value is sensitive or specific for shock. Shock is a clinical diagnosis. Okay, so that's my RCMP today. I hope everyone's still awake. Thank you. Any question? Any announcement, boss? Okay, and anybody want to add, especially the master student? Because here sometimes I actually motivate to the team because the presentation is very, very interesting. If there's like to come room, then number two, I think maybe you show to the super because you have to make sure that whatever presentation is beneficial to all your MOs, because remember some of the MOs datang dari rumah, ada yang on leave tapi dengar, so you have to make sure your presentation is very informative lah, which is very good. And then you cover a lot of physiology, which is not pure physiology, but relate to the clinical, which is also very good. And of course, you touch the ultrasound and then the types of the shock, which is, I think, everyone should actually, kalau you tak pernah dengar shock, you dengar this lecture, I think it's very, very good as well. And the way Jocelyn conduct the CMEs is actually one of the ways to know that you understand the presentation is to audit back. So what she's trying to do just now is actually to relate back whether audience understand or not. Sometimes you tanya, tak jawab, but when you throw questions, so you know that at least the audience understand. So I hope that the next, this is the level of presentation that actually we want at the level of CMEs. Okay. So any other masters nak or the specialist want to add? Masters kalau tak add tak boleh lah, because MO present ni kan, so
Actually, just want to add a bit on lactate, because there is the latest study on Andromeda study. So instead of increasing our lactate, our sleep restriction, our end target, what do we want actually? We don't want all patients to be lactate less than 2. So in Andromeda study, they actually compare your CRT and also lactate. So instead of repeating lactate regularly, you're inputting UVG, wasting the money resources, we actually look clinically at the CRT. If the CRT prolonged, you already know patient is already in shock. And not every patient that lactate is high is in shock as well. You need to be assessed clinically, because you need to know the type A and type B lactate. Type B lactate can be B1, B2, and B3, which can be due to inborn error metabolism, can be due to underlying disease and liver disease, can be due to medication, some patient on salbutamol syrup, or some patient on metformin, all that can cause lactate to be high. So at the same time, after 3 results, you want to look at lactate, instead of repeating the UPG regularly, look at the CRT actually. So they say the comparison is actually similar.
So I just very basic lah. Basically, for from what Dr. Hong has presented, one the MOs, especially the new ones, when you see patient comes with low BP, do not straight go to for fluid bolus. Basically, you have to work out what is type of shock of the patient. Memang most of the time patient is hypovolemic, most of the time, right? The macam tadi Dr. Hong kata ada 4 types of shock. So please remember, have your the knowledge back of your mind that not necessarily patient needs fluid bolus. Maybe the obstructive shock. So if you give more fluid, it will cause more harm to the patient. So first, work out what is the cause of the shock first, then only you manage. Even the management tadi yang Dr. Hong bagi tu yang if you want to intubate, you have to give roketamine. Basically, you have to look of the cause of the shock first, then only you can manage. Okay?
I would say good presentation, and it benefits all, especially master students, but not to forget our junior MOs and also household. Okay, in response to what Dr. Shani has said regarding so if you see Dr. Hong had presented regarding static and dynamic response for food challenge. Okay, not to forget, sebab kalau tengok the presentation, all of them static tu dia ada C6 kan, benda-benda yang static lah, but not to forget one of the static response adalah your clinical judgment. Okay. And then dynamic tu yang nampak stroke volume variation lah, which is high end, which kalau tengok ultrasound kita cuma ada 2 yang ditolak ke sana ke sini. Okay. So nanti bising betul semua korang punya ultrasound result kan. So not to forget you punya clinical judgment, your altered mental status. Sometimes you tengok after one time patient mental status dah improve. Okay, your CRT, what Dr. Shani have said, okay, your urine output, your pulse volume, always touch patient. I know kita ada altering and urine, but kalau sebab sekarang kita punya apa, our PPE dah diberi kelonggaran kan. So I think it's not apa, tak ada reason nanti kita tak masuk untuk tengok dan assess patient, assess daripada luar je. Always touch your patient. Yeah. Not only transfer straight away, but we have to touch the patient to what is the response. Okay. Rather than on this slowly apa, depends pada dia punya ultrasound. Tengok BP, pulse rate, coming down or not. Okay, like that. Sebab kita tak tengok single digit. So sometimes kita tanya kenapa ambil BBG, kita nak tengok lactate. But kita basically tengok lactate clearance juga kan. Okay, but before you go to lactate clearance, we should see the patient clinically. Okay, not to forget the clinical injection. Okay.
Okay, Assalamualaikum and good morning. Yeah, very good presentation. Just wanted to highlight a few things. Yes, I agree with Dr. Azman. Don't forget our history and physical examination. Okay. The other thing is just to help us to diagnose the condition. History and physical examination. I think last few weeks we got 2 cases of tension pneumothorax which just diagnosed after X-ray, which I think is not right. Okay, from the history and examination, we should able to diagnose and do the treatment. Okay, X-ray just to confirm our diagnosis, not the other way around, which we diagnose after we got the X-ray. Because there is tension pneumothorax and is how to say, tak boleh kalau kita tak dapat detect sebab it's a very large pneumothorax. Okay, it's not trauma case, it's spontaneous and it's tension pneumothorax. Okay, please examine properly the patient. Okay, and history. The other is just to help us. Okay, yeah. And for especially in septic shock, please okay, after assessing the patient, please start the fluid management as early as possible, and give jangan takut sangat nak bagi 10 cc per kilo patient. Kalau memang dia punya, kalau kita dah assess dia punya IVC and patient in severe dehydration. Okay, don't afraid to give boluses. Okay, and we can also start early micro. Okay, we can overlap with the fluid bolus because we don't want the patient to have a dirty trust in any presentation to us. Okay, so yeah, okay, terima kasih.
Actually, responsibility is kita tengok apa yang doktor present, kita bagi fluid. Tapi jangan salah faham, kita cakap fluid is treatment. bila cakap food responsiveness ni, bila kita cakap passive raising test ni, basically kita nak tengok patient tu dia boleh terima feed lagi ke tak. Itu dia punya keyword lah. So kita by doing reverse random back, basically kita angkat kaki kita kan decrease patient flat. So actually kita auto masukkan balik dia punya venous return masuk balik ke dalam hati, dan kita tengok patient tu terima lagi ke tak by tengok dia punya response, stroke duration, BPI, pulse rate, dia ada lain lagi lah parameters yang lain, pulse pressure, semua tu. Okay. So bila kita tengok patient respon dengan ada apa, dia ada measurement buat 20% macam tu, so baru kita kata oh patient tu boleh terima lagi fluid, dan baru bagi fluid. Tapi kalau dia buat PLR tu, patient tu tak ada respon, sebab patient tu bukan fluid responsif lah. So itu apa maksud dia tadi silah, sebab saya takut salah faham responsiveness, angkat kaki ada bagi fluid apa itu. Kita tengok patient tu terima lagi ke tak, itu tujuan dia sebenarnya.
Yang tadi tu ada case scenario that you put up kan? Ada yang pasal patient yang elderly sikit tu. Just now somebody said that the blood pressure tu not so worry.
Stronger?
Okay, so ada benda yang you kena careful bila you tengok blood pressure patient. Patient yang tua, elderly, dan patient yang ada hypertension. Okay, so kalau patient tu dia elderly, most of the time kan you have a blood vessel dia tu dah keras sikit kan. Most of the time dia orang blood pressure akan tinggi sikit. Okay, then kalau patient tu hypertensive, kalau you tak tahu baseline tu, you kena be careful lah kalau patient tu datang dengan BP 110. Kalau you boleh tanya baseline patient BP tu, BP patient tu you tanya. Sebab most of the time patient yang hypertension, dia boleh sumbung ubat ke semua tu, dia tahu kata dia punya baseline berapa, dia pergi check semua kan. Jadi tanya patient dia kata, oh biasa saya punya tekanan darah 140, tapi sekarang dia datang dengan 110. So yang tu you kena keep in mind, patient yang non-hypertensive, elderly, okay, and then with regards to heart rate, careful dengan patient-patient yang manual laborers, Indonesian, Myanmar, apa semua ni yang dia orang kerja keras semua tu kan. Most of the time dia punya baseline is low, 50, heart rate dia biasa 50 kan. Datang dengan 90. Bila datang dengan 90, kita macam oh okey lah, not so bad kan. Tapi sebenarnya heart rate dia yang biasa dengan 50. Yang tu juga dia jaga juga kan. And then the urine output, bila you monitor patient yang you tengah resuscitate in shock kan. You selalu monitor juga urine output kan. Tengok, okey kita kan careful kalau patient-patient yang dia memang ada uncontrolled diabetes semua tu. Benda tu pun boleh mengaburi mata kita juga sikit. Okay, thanks.
Sebenarnya pada Dr. Fazrul will be like action. Everyone knows him. Input from Dr. Fazrul is highly needed.
Right. Well done to the presenter, the first presenter. I think your slide is very good. Just that, can you please go back to the situation? It's like you have really studied your presentation well, and you benefit from almost all groups of doctors here. Kalau boleh tengok dekat dia punya slide yang tadi, yes, okay, alright. I think C is not just about vasoactivation and fluid responsiveness, but it's also to look into, do not forget about your advanced life support. Okay, you look at unstable tachycardia, okay, that is also, especially for the junior doctors, jangan hanya think that if you low BP, that you need to actually start on fluid, because you have to do ECG and you think some other this patient actually having a, tachycardia, but actually ECG because SVT is an unstable SVT, so VT, okay. And I reckon whatever that have been said by the other specialists about the ultrasound. Ultrasound is just an adjunct. It helps you to see what's actually going on with the patient, but never to forget the history and physical examination, because that is actually the most important part. in assessing the patient who comes in with shock. Well done.
Okay, so banyak input. I hope that you guys can take every input seriously. So bila semua dah cakap, so the last person usually dah hilang sikit idea lah. Majority yang saya dah cakap tu telah diberitahu oleh mereka. Tapi one thing I want to remind all of you is that very important for MOs and housemen. Okay, basically MOs in emergency department, I think MO in emergency department is the only MO that actually looks the patient as a whole. And then your physiology, apart from NS but I still think that we are also at least the par with NSMO. Apart from look at the patient as a whole, MO in ED should have a highest knowledge of physiology compared to others as a discipline, right? Because by knowing a physiology and of course a bit of anatomy memang something kita out lah, the skill like banyak kan, but physiology will actually boost up your confidence. Alright, so that's why it's very, very important for you guys to know physiology, and then so physiology of the shock is the best to actually keep in mind, because that's our bread and butter. So nobody else should know about shock except for ED, because we deal with ED. Patient come to ED with a shock situation. Dan satu lagi, bila patient datang ke emergency department, dia datang dalam phase yang agak interesting untuk ED kan. I thought that emergency physician, whether we like it or not, our trade memang kita ada attention deficit sikit, yeah? And then kita cepat irritated sikit. So when the patient comes to emergency department, the physiology is very, very interesting during that time. So you can play with the physiology. By the time stable, dia pun dah macam then you send the patient up. So orang up, dia orang hanya terima patient yang stable. Kalau tak stable, you akan dengar B7 complain kan, right? So dekat atas tu doesn't think much about physiology tau. So macam I pun tak sure bila you admit patient dah stable, boring kan. So the trait of emergency physician bila dah stable tak lah boring cepat buat. So that's why your physiology is a lot better than other discipline. So the key word is that please don't be humble when you refer the cases to other discipline. Use your physiological knowledge and your experience, your resuscitation when you want to refer to the team. Don't let them actually make you feel a bit down, because mereka tu sebenarnya tak ada apa sangat, ya. You refer kat orang bukannya macam orang something higher than you. You refer kat orang because you kena admit division. Yeah, the ward is actually taken care by them. Of course, we have to knock the door first when we send the patient up, right? So please feel good about yourself, especially if you have a good physiological knowledge, right? Dan satu lagi, I'm not so sure siapa yang ada kat sini dah lama. Siapa yang ada sini MO yang masa datang sini asmah datang buat rounds kat sini? Tak ada. Okay. If I may say to you, the more senior you become, the more wisdom you have, you'll be more going to the basic. Kalau tak percaya, tanyalah senior-senior ni. You akan check basic. So sometimes we will be irritated bila buat rounds and kata yang tu tak boleh discharge, BP dia low risk sikit. Yang tu tak boleh discharge, BP dia low risk sikit. Masa kita tengok dari jauh, patient tu nampak clinically okay. Kan sebab tadi Hong ada present, how do you assess clinically? Nombor satu is actually of course the vital signs. Yang kedua, you look for evidence of peripheral shutdown. So mental status dia duduk macam relax makan. Lepas tu, kadang you approach the patient, you borak-borak. Sambil borak, aku tak tangan ni, dia kejut. Kenapa aku tangan ni silap lah. Rasa tangan sikit, baca semua kan, the post is very, very good. Lepas tu kita tanya, are you sure the BP is low? BP dia memang low, doktor. Okay, so the moral of the story is that you trust yourself better than machine. There's a lot of things that you can feel and conclude with just feeling the pulse. Okay, disebabkan nak bagi rasa pulse tu dekat counter triage tu dulu ada cermin, ya, we remove it because bila ada cermin dekat depan tu, the paramedic tend not to feel the hands, right? So sometimes you nak triage a patient, you buat CCTVR kan? So by putting at tangan dekat tangan your pulse, you boleh rasa volume, you estimate the rate, yang you tak payah kira pun sama 1 minute. You boleh tahu rentak ada pun, you dah agak, oh this is normal. Right, everything will go to the pulse, right? So masa that I remember masa I ikut dia round just nak visit someone, but then kebetulan dia pergi kat observation, dia kata dia tak, I just nak jalan-jalan, because I dah lama tak buat medical. She's a ONG specialist kan, she was. Saya kata, but why not? Lepas tu, dia pegang, cakap dengan one of the patients, and then tangan dia, I nampak pegang pulse. Saya kata, okay, she is maybe 80 something. She's still doing the basic things. That's why even though bila you become more senior, you will know very, very important to show the pulse. Okay, alright. So, ada apa-apa lagi kan nak buat announcement?
Yeah, just ada short announcement. This is regarding Code Blue. I think kalau nak cerita pasal Code Blue, I need 5 to 10 minutes lah. I think I will do a CME, short CME in coming weeks. This is just not inform, especially for the senior lah yang dah tahu what is Code Blue, who goes for Code Blue semua. So after you dah attend to the case, you dah balik ke ED, and you dah stabilize the patient, basically you have to fill in this form. Form ni dah ada lama dah. Even masa I join kat sini pun dah ada. I'm sure you guys tak tahu pun benda ni. First time tengok kan, kita ni pun tak tahu. So basically this form dia ada dekat Yellow Zone, dekat bilik ubat. Bilik ubat kan belakang tu. So dekat sana ada Code Blue punya response back, and also this book. So after you dah respond to the case, balik fill this form. Basically simple je, the details of the patient, but the size and to when for the case lah. So tak apa, dekat ni saya do sesi talk more. Kalau tak ada apa-apa from any of us, I think we finish our first meeting.
Reminder kat MO, kita ada logbook kan? Okay, I would like to remind regarding our CNP. So recently kita dah hantar kita punya syarat untuk kita tengok logbook, and then kita hantar pada quality untuk CNP. Okay. Sayang ada sebab bila korang tak cukup logbook tu, so bila kita hantar tu, bila kita check tu, so ada sesetengah prosedur yang kita tahu, kita kenal korang memang buat CDL lah, intubation lah, tapi sebab tak isi logbook, kita tak boleh nak penuhkan korang punya CNP tu. So contohnya buat ultrasound je, padahal dah buat banyak intubation semua, tapi sebab tak isi logbook tu, kita tak boleh nak apply untuk intubation. So sayang lah, padahal kita tahu, tapi bila kita black and white nanti, bila kita audit nanti, kita tak boleh nak jawab kalau logbook kosong, tapi kita lepaskan CNP untuk intubation, which is not right lah kan. Tapi kena faham CNP tu actually contact you juga. In case kalau ada medical legal, ada macam salah buat prosedur ke, nanti dia orang akan question this particular doctor, adakah dia di privilege tak untuk buat intubation. So nanti dia akan tengok balik di CNP. So that's the important of CNP. So isi logbook betul. I know you busy, tapi just isikan, saya rasa ada 10 prosedur, ada 7 prosedur dan 10 je tempat kosong. Please fill in. Thank you.
Sekali, do you actually compile all your presentation masa CMEs dalam satu chart? Ada tak? Kalau tak buat, I selalu kena remind. Because our practice is that siapa yang present CME masa on teaching day hari ni for CMEMOs, we compile into one file dekat dalam file jabatan. It's okay, you nak convert jadi PDF tak apa kalau tak ada orang ni. Reason is actually we want to share. Sebab sometimes macam hari ni punya presentation, I think ada yang make notes, saya tahu macam dia tulis notes. I mean she can just go to the presentation and then just print out for to study. Right?
Actually, most of the presentation is thrown inside this computer. When you go into the desktop, it's full of presentation on the on the homepage.
Okay, nanti lambat dah start. Maybe someone can just make it more systematic letak dalam satu presentation CMD so that you can always share. Right? Share. Okay, good. Tapi yang terang you akan delete kan, so satu-satu dapat reference. Okay. Satunya Alex buat kan, alright. So Alex ambil dia akan simpan dalam mungkin bukan file jabatan, ada file CMD so that we can share. Alright. Okay. Kalau tak ada apa-apa, I guess. Okay. Saya masih trying very hard to get the sebenarnya polisi dah lama keluar in 2021 to say that RTK is enough for admission. Number two is actually recent MDAC meeting which is attended by the HODs of the very important specialty has agreed upon using RTK as enough to admit, right? But there are certain cases that especially when clinical and history suggested of COVID but RTK is negative, so those are the cases where they actually want to do PCR. But the ratings of the ward medical has just discussed last week. They tried to find some beds for PI, PI patients, so that this patient would need to be wait at D for PCR. It's just that they need time because kita sebenarnya dah lama ready to hybrid, but kat atas tu ada some challenges that they are preparing towards hybrid as well. So one of the suggestions that we gave is actually we really need a place to put a patient that they want PCR because that's not our problem anymore. Even if we bought the RTK with our own money, not hospital money, because we anticipated to become hybrid anytime soon when government announced pasal peralihan endemic, right? So I put to you guys not to do PCR as a routine, right? So you all ambil RTK tu cukup. So kalau let's say the primary team insists on PCR, just look at your spoken dengan our specialist, ataupun kalau you rasa memang indicated, really indicated, and sometimes RTK negative, tapi sebenarnya nampak chest X-ray something, you can actually do, just inform the pakar lah. So those are the cases that we want to push up with the RTK result to the isolation ward, but of course it's very limited up there. So at the specialist level, it's specialist to discuss lah. So eventually on round 0 people, ED, orang atas memang tak ready lah, mesti dia nak result PCR dan ED, tapi we have to push. Okay, it's our department, so we have to start being a bit stern, right? Especially specialist level. Even kalau you dapat code blue or variant daripada PKKN publish unstable tu, we have to put a stop to that so that they will learn independently lah, right? Because otherwise akan bila ED nak kena cover PKKN kan, right? So we try to help but not at the level that kita dah tak boleh nak survive, right? So if any problems that you receive regarding the PCR, please relate to the pakar. And satu lagi, I know that there's a problem in contacting the ONG specialist, MO semalam kan. So for ONG, kalau sekali you call tak dapat MO call, you just call the pakar call. Right? Kalau you tak berani nak speak to pakar, you can just talk to pakar lah. Because for ONG, I think Dr. Nora really enhanced the pakar. So some of the decision, even if you refer to the MO pun sometimes susah nak dapat decision. So kalau you call the MO or call, tak dapat, tak angkat, maybe twice tak dapat, you just call the pakar. They don't mind that our MO called them. Right? Okay, kalau tak ada apa-apa, thank you very much.
Thank you. Food is ready with nasi lemak.
Dia mau tak support you present. Macam mana you present balik kat I nanti?
Boleh.
Perform the present. Okay, I off mic ni. Off. Ni, pergi Alex.